And good evening, everybody. Welcome again to our Wednesday webinar session. Today, we're very lucky to have one of our mentors who has joined us quite a while back, actually, and we're very pleased that he can come with us today. He has been working in Cork University Hospital, and he's going to give us a talk on Patella Instability. Before Mohammed Ansari starts his talk, I just want to remind everyone that the Viva session will come at the end of this webinar, and that's not recorded, so please volunteer for the hot seat session there. And also, if you have any questions, please type it in the chat and we'll answer the questions near the end. Thank you very much, Mohammed. Really looking forward to your talk.
Regarding anatomy, patellofemoral joint consists of the articular surface of the patella and the articular surface of the trochlea. It is a gliding joint, and the patella have the thickest cartilage in the body, and it is a largest sesamoid bone. It has two surfaces, anterior and posterior. Anterior surface give attachment to the quadriceps tendon proximally and the patellar tendon distally, while posterior surface is distal 1/3 or 25% is non-articular, and the proximal or 2/3 is articular. While it has two facets, medial and lateral facets, separated by a ridge. We'll go into detail of more detail afterward. And then the trochlea is the other part of the joint, which is the articular surface of the distal femur, and it has a groove, and the diameter of the lateral femoral condyle is more than the medial femoral condyle, and lateral condyle is longer and higher, as we can see in the picture. This is regarding patella geometry, that it has two facets, medial and lateral facet. Normally they are equal in size and they both are concave, and we can classify according to Weiberg classification. The type 1 has equal medial and lateral facet, which both are concave, while type 2, there is medial facet is smaller than the lateral facet, but still both are concave, and type 3, that the medial is smaller and convex as compared to the lateral side. And then come the trochlea geometry, that trochlea is over the anterior surface of the distal femur, and it has two condyle, medial and lateral, in the form of the ridge, and we can classify according to DeJour classification, and that classification is based on the CT scan or MRI, the axial images. The grade A, it is normal trochlea or shallow trochlea with shallow groove, and if we see on the lateral view of the knee, as shown in the diagrammatic representation of the X-ray, there will be no crossing sign. These two lines will not cross. And grade B, there is flat or convex trochlea, and on the X-ray we'll see the crossing sign. These two lines will cross each other. And grade D, there is hypoplasia of the middle femoral condyle. Grade C, there will be hypoplastic middle femoral condyle, and this is the picture, the last one, which will show that there will be the double contour line, and the axial section will be like this. Then this is the picture where we can see the fourth classification, fourth grade D, and we can differentiate between C and D. That in the C, the medial femoral condyle is hypoplastic, while in D, there's a cliff pattern. We can see in these pictures. Then regarding function of the patella, there are three main functions: that it provides a long lever arm for cord, which increases the power of the cord and the efficiency of the cord muscles. Second one is that it decreases the coefficient of friction cartilage on cartilage. If there is no patella, then patellar tendon or cord tendon has to rub against the trochlea, and that coefficient of friction will be quite high as compared to coefficient of friction of the cartilage on cartilage. And the third one, that the vastus medialis, vastus lateralis, and vastus intermedius and quadriceps femoris, they all attach to the patella. And patella provide the centralizing divergent forces It centralizes the divergent forces of the cord, these all muscles. And then come to the sum of the biomechanics, which are important for the stability of the patella, that there is normally Q angle, that is the Q angle is between two lines, one line drawn from the anterior superior iliac spine to the center of patella, and from center of patella to the tibial porosity, the second line, the angle between is the Q angle. And with normal Q angle, still there is a tendency of the patella to sublux laterally. And if this angle increase, the tendency of the patella to sublux laterally will increase. And to keep the patella in position, there are different restraint provided by the nature that is important for the stability of the patella. And we can classify, or we can divide into static and dynamic. Static again can be divided into bony and soft tissue. In the bony, the shape of the patella, as we have discussed earlier, the Weber classification, medial and lateral facet. And then second one is shape of the trochlea. According to DeJour classification, we have seen 4 grades. We have discussed 4 grades. Then the genu valgus, or the alignment of the lower limb, that is the Q angle. That I have discussed, that if Q angle increase, the lateral subluxation forces will increase. Then the next one is the rotational alignment of the lower limb, which is important, that if there is femoral anteversion and tibial extorsion, that will increase the lateral subluxation of the patella. And the next one is the soft tissue. The most important is the MPFL, medial patellofemoral ligament, that provide about 50% strength to oppose the lateral subluxation. And there is medial and lateral patellar retinaculum. They also provide the stability to the patella. And then the main classification, next one, the dynamic. Dynamic is the quadriceps tendon, which I already told, that consists of 4 muscles, and they provide force to keep the patella in the center. And the vastus medialis is most important, which keep the patella toward the medial side and oppose the, or resist the lateral subluxation of the patella. And then we can divide the patellar instability. This classification, by this classification is not so common, but we can divide into these three types. Acute traumatic type, and that trauma can be direct or indirect, and mostly it is indirect. And then the chronic hyperlaxity type, which is usually in female with the high Brighton score, and could be habitual, that is painless, and that is because of tight lateral structure. And then come to the assessment of the patient with the patellar instability. The patellar instability will assess with the triple assessment: history, examination, and the investigation. And there is a BOA guidelines are there for the patellar instability assessment. And I will discuss that one later on. That is almost same, which I will tell here. So first of all, we'll take the history. In the history, important points: the age. Age is related, is important for the treatment of the patellar instability, and also that it is less common in the old age as compared to the young age. And then is the mechanism of injury of the first event, which will dictate that what type of patellar instability is this one. And then how many time it was dislocated. Is it first dislocation or recurrent dislocation? That will also dictate our management. And then what symptom patient can have for the patellar instability. Number one, that usually they are presented with dislocation, but they can present with the subluxation, pain, or giving way also. And then also the important point that we have to inquire, that does the patient have double jointedness or no? And regarding the examination of the knee, this is my system of examining the knee. Everybody will have his own system, but there are some important points which we have to look. First of all, the inspection from front, from side, from back. And in the inspection, we'll look for any malalignment, any deformity, any asymmetry, and especially the valgus knee and the rotation of the lower limb. And then we'll check the gait. In the gait, the important thing we have to see that is in-toeing or ex-toeing gait. Then we'll ask the patient to sit and check for the J sign, that is patellar tracking. And then we'll ask the patient to lie down, and we'll do the full examination of the knee in that. But the special interest regarding this topic is that we'll do the patellar apprehension test. We'll do the Clark test, which is patellofemoral friction test. This is quite painful, but we have to take care, do it very gently. Then patellar tilt test will tilt the patella and see that how much degree it can be tilted. This will tell us about the laxity of the medial and lateral structures. Then patellar glide test will glide the patella and we'll see that how much it glide to medial and lateral side. And then the patellar from capitation to see if there's any arthritic changes have started or no. And then I will put the patient on side and check for the iliotibial tightness by the Ober test. And then I'll put the patient prone to do the rotational profile. And at the end, biting score. Regarding investigation, there are 3 types of investigation which we can do: X-ray, MRI, and CT scan. In the X-ray, we will usually do the AP, lateral, weight bearing, and the skyline, and sometimes we have to do the long leg film. In the lateral view, we can judge different factors. One is the patellar height. For that, we should know that Cat and Deschamps ratio, and there are different ratios: Blackburn Peel, Insel Salvati, and Blumen Sart. There are different criteria to measure the height of the patella, which I will discuss later on. And then we'll see the trochlear dysplasia, which I have already mentioned, that we'll see the crossover sign, double contour sign, and trochlear spur. In skyline view, we will see different angle for the trochlear dysplasia, that is sulcus angle, patellar tilt, congruous angle, lateral patellofemoral angle, and patellar dysplasia. And if there's any deformity, then we have to do the long leg film to address for the check for the more details of the deformity. We will do the MRI scan, and there are different protocol in different hospital. In my center, the protocol is that for the first dislocation, we are not doing the MRI, but if it is recurrent, we are doing the MRI scan, second dislocation. And why we do the MRI scan? We can see the MPFL continuity, and also we can see TT-TG distance, and any osteochondral lesion, any kind of arthritis. And we can do the CT scan to see the patellar and trochlear dysplasia and to assess the TT-TG distance. And this is a better way as compared to MRI to measure this one. And this is the, in this I will describe later on how to measure the TT-TG distance. Then this is the X-ray of the knee, and here it is showing that there is, crossing sign, and this is because of the flat trochlea, and there is particular spur we can see, and there is double contour we can see, which I have already mentioned in my previous slide with the help of the diagram. And this is because of this double contour sign because of the hypoplasia of the medial femoral condyle. And then we can see the on lateral view patellar height, and at 30 degree of flexion, the Blumen-Sart line is at the level of the inferior pole. This is one of the criteria. Then there are different method of measuring the height of the patella, and that is one of them is the Blackburn Peel index, and this is the distance between inferior pole of the patella to the articular surface of the tibia, and divided by the articular surface of the patella. The normal range is 0.5 to 1. The other one is Caton Deschamps, and that is distance between inferior pole of to the articular surface of the tibial plateau and divided by articular surface of the patella. This is between 0.6 to 1.3. And then Insel Salvati ratio, that is length of the patellar tendon divided by length of the patella. Normal range is 0.8 to 1.2. So these are the different methods by which we can measure the length of the height of the patella. And we can use any one of them. Usually we use the Blackburn Peel ratio or K condition. And on merchant view or the skyline view, these are the different angles which we can see. The congruous angle we can see here. This is the between the two lines. One is perpendicular to trochlea, the trochlear deepest part, and then one line through the thickest part of the patella at the junction of the medial and lateral facet, and we measure the congruous angle. This is the congruous angle. Then there is sulcus angle. This is the sulcus angle, the dotted line. And then lateral patellar angle from one line along the anterior edge of the lateral femoral condyle, lateral and medial femoral condyle, and one line along the lateral facet. And this is lateral displacement we can see. And this is the diagrammatic representation of measure of the TT-TG distance. We have to measure the distance between two lines. One line from tibial tuberosity to the posterior cortex in one cross section of the C. In the other cross section of the C, one line from the trochlear groove to the posterior cortex. And that is in between these two lines, this is distance, this is a TT-TG distance. Then come to the management. The management will be according to the BOA specialty standards. And I summarize these important point here that patient will be managed with the MDT. And if needs surgery, then that will be according to the cause and underlying etiology. And should be done, this surgery should be done by a specialist surgeon who used to do these type of surgery. And the next one is the pre and post-op rehabilitation should be by the specialist physio. In children, we should do the fascial sparing procedure. We should not do the tibial tuberosity osteotomy or tibial tuberosity transfer in children. And if we have to answer that how I will manage the patient with patellar instability, this is in general that I will manage him according to MDT, and MDT will include the orthopedic surgeon, orthopedic sports surgeon, which have special interest in knee surgery. And also we have to include the specialist physio and the occupational therapist. And the treatment will depend upon patient factor and condition factor. Patient factor will include the age, the activity level, and the comorbidities of the patient. Activity level mean that if there is any, what is the sports activities, what is the occupation of the patient. And regarding condition factor, that will be that what is the underlying etiology. That I will discuss now later on. The first line of treatment is physio in all the patient, and that is the knee muscle strengthening, especially vastus medialis obliquus. And if the non-operative treatment fail, the operative treatment. And then operative treatment will be according to the underlying etiology. This is one of the scenario. If there is a patient presented with recurrent stability and we do the MRI scan, we found that there is MPFL tear, then we can do MPFL reconstruction with the help of auto or allograft. And in my center, we use usually the autograft, hamstring graft. And repair can only be done if there is bony fracture or bone avulsion fragment is there. Otherwise, reconstruction we have to do. And other scenarios that if a patient presented and we investigated, we do the axial CT scan and TT-TG distance is more than 20 millimeter, then we have to do tibial tuberosity transfer. There are different methods. One is the Elmsley-Trillett transfer, in which we transfer the tibial tuberosity to the medial side. And if there is MPFL tear is there, then we have to do the MPFL reconstruction also. And second one is the Fulkerson transfer. That is the anteromedial transfer of the tibial tuberosity plus minus MPFL reconstruction. If there is patella alta, if the Caton-Deschamps ratio is more than 1.3, then we can do the distal transfer of the tibial tuberosity. If there is patellar chondrosis, early osteoarthritis, then we can do the anterior displacement of the tibial tuberosity, and that is the Fulkerson method. That's the anteromedial transfer of the tibial tuberosity. And if there is severe lateral patellar compression syndrome, the lateral structure are tight, then theoretically we can do the lateral release, but practically nowadays we are not doing isolated lateral release. It is usually indicated if there is excessive lateral tilt or tightness after medialization of the tibial tuberosity. And if we found that there is trochlear dysplasia, then we can do the trochleoplasty. And if patient presented late and there is a patellofemoral joint arthritis, then the option is the patellofemoral joint arthroplasty. And if there is osteoarthritis in the other compartment, especially in elderly, then we have to do the total knee replacement. And if all failed, that is, if there's any fracture of the patella or resurfacing not possible, then the option is patellectomy. And if patient is a child, then same principle as adult, but in general, most preserve the physis. Do not do tibial tuberculostomy. That will harm the growth plate of the proximal tibia. And if we do the patellectomy, we have to explain to the patient that there is decreased power 30 to 50%. And this is the BOA specialty standards for recurrent instability assessment. And these are almost the same which I have discussed with you in my slides. And this is the surgical manage according to BO specialty standard. This is also the same which I mentioned in one line. And those are that is a brief, very brief summary of this guideline. And that's all. Thank you very much.
Thank you very much, Mohammed. That's very good. It's not an easy topic. I have to agree. When I was reading this up, there were often multiple operations for the same pathology treatments and multiple options. Can I ask you, when you were talking about your preferences, are these things you would do normally in your practice?
No. MPF reconstruction we do usually, and the tibial tuberous transfer rarely. We do, but rarely.
No, I agree. I said that's what I was thinking it would be. Is there any questions from the audience?
Yes, I have a couple. So thank you very much for the talk, and it is very focused on the FRCS exam. One question: are merchant view, skyline view, sunrise view all synonyms?
I think so. Yeah, maybe Sean can correct, but I think they are same.
I think they're the same, but one is from one side, from the superior, while the other is from the inferior. I just can't remember which order they are.
Yeah.
I'm not sure which one was skyline, which one was merchant. I think sunrise is probably the same as skyline, if I remember correctly. I'll look it up and I'll get back to you on that.
I think the aim is the same as to, and the angles are the same. So that's the main point. Is the pure anterior transfer of the tibial tuberosity, what is the name of the surgery? Is it Fulkerson or Maquette?
Maquette. It should be Maquette. No, Fulkerson is the anteromedial transfer.
Anteromedial, yeah. Yeah. Someone has flagged it in the chat that the skyline is prone and 115 degrees of flexion. That's all the questions I have till now.
Yeah, I think that is correct. The skyline view is prone, while the merchant view is supine. But it's pretty much, it's just the way the X-ray is taken. It gives you the same information.
Yeah, the same angles, so not to be misinterpreting anything. Any role for isolated medial patellofemoral ligament reconstruction?
We used to do, if there's MPFL rupture, tear, and I have seen most of the procedure which we do, and that is the MPFL reconstruction, if it is torn. But it depends upon the underlying etiology. If there is, suppose, TTTG distance is more than 20, then isolated MPFL reconstruction will not do the job. We have to address the etiology. What is the underlying pathology?
Thank you.
Omar.
Good evening, everyone. Hi, Mr. Ansari. Hi, everyone.
Hi, Omar. How are you? Sorry, please go ahead.
I'm fine. Okay. So paraclassification basically about 4 classes of for patella instability in general. Type 1, where the patella is the first time dislocation we meet it in the ER. Type 2, when the patient presents with recurrent patellar instability for multiple times, which is the most common type. And it's also divided into 2 sections, where the recurrent patellar subluxation or 2 or more patellar dislocations. My confusion is always between type 3 and 4, where type 3 is a dislocatable patella. I believe this when the patient presents to us to the clinic rather than the ER, with passive patellar dislocation or a habitual patellar dislocation in every flexion and extension, while type 4 is the dislocated patella and is divided into type A and B, whether it is reducible or irreducible. So any idea about this classification and its significance to treat the patient, or how it guides the treatment?
The initial, it is the initial classification which you told that first time and second time recurrent. That is controversial. I have seen before in some center protocol was that first dislocation, just physiotherapy and send home. If he come again, then we'll investigate further with the MRI scan and go for the treatment. And nowadays the trend is changing in my center also, that if young patient and this is first time dislocation, then we are doing the MRI scan. If there's MPFL tear, then we're going for the MPFL reconstruction. So I mean, this I know. I don't know about the periclassification even, so I can't say
how it can guide management. Okay, thank you.
Omar, what I suggest for the FRCS exam, and anyone that's sitting the FRCS, I wouldn't suggest using first or even second patellar dislocation as an indication in younger patients to go to an operation. I know some centers are doing it, but that's not the traditional knowledge of your examiners at the moment. Does that make sense? So you are
perfect sense there.
Controversial if you say on the first dislocation or second dislocation you're going to go to operative, because operative is an option only after exhausting non-operative options. Does that make sense?
Yes.
Of course, if you
completely agree with you.
Structural abnormalities that non-operative is not going to work, that's fine. You can argue that in the exam, but you are going. It makes more sense as a safe year 1 DGH consultant to say, I will exhaust non-operative options and discuss this with a specialist in young knee patellar dislocation specialist. Does that make sense?
Perfect sense. Thank you very much.
Any more questions?
Yes.
Can I add something? Okay.
Yeah. So for if there is any tightness in the lateral structures, what is your surgical recommendations?
if there is any tightness, then we have to release from inside the lateral retinaculum, which usually we do. And I have already mentioned that there is no role of isolated lateral release nowadays. It is usually combined with the other procedure. After doing those procedure, if still there is tightness, then we are doing that one. This is
good. Thank you. And for the medial patellofemoral reconstruction, would you use always autografts, or you can use synthetic grafts?
We usually use autograft from the hamstring unless we don't have the hamstring. If some patient is reconstruction done bilaterally, then we have to use the synthetic graft.
Okay. And if you want to distally translocate the tibial tuberosity of the for a patella alta, would that decrease the degree of flexion of the knee?
I will say theoretically yes.
Yeah.
But practically, I mean, I have seen very few cases, maybe one case for distalization. Usually the end to medial transfer we have seen. So I will say that I have no experience what will happen, but theoretically, yes, it looks like that it will decrease the flexion, but I have no experience. I can't say with surety.
And what is the most used autograft? Is it gracilis or Semiti?
Semiti.
Okay. Yeah, I think other questions are answered in other have been answered as well. So thank you very much for that.
You're welcome. No problem.
Cheers. Thank you.
I have something to add. So regarding the TTG, actually this paper is poor. Actually, this is a French paper published in 1998, and it's relied on the CT scan to measure the distance, and it ignores like the cartilage thickness, which is very thick in that area. So you can mention that in the exam, but if you mention that the quality of this paper is not good, it ignores the cartilage thickness, and it is like a wide, it's like the normal of 10 to 15, and it shows a very wide range of like of normal parts. I think it may give you more mark in that, and don't rely on that in taking decision. I don't think that most of the knee surgeon rely on the triple TG in their decision nowadays.
Okay. That's correct. That's very good. Thank you, Han. Mohammed Ansari, thank you so much. It's a very good talk. As always, enjoy your presentations. Comprehensive, well orientated to the FRCS, and a very good set of questions from our participants. Today we had a total of 60 participants. And always, guys, I strongly recommend reviewing these videos when they come up on the YouTube channel and on our webpage. Keep an eye out for further webinar sessions and dates, and please do register in advance. And we still have, I think we're opening some new Viva practice courses specifically for the June exam as well. So keep an eye on the mentor webpage for those if you need to register for the June exam. And as always, you can claim CPD points by contacting us on the Telegram group or emailing us directly at frcs.co.uk. You can get the email contact address there for the CPDs for this webinar. And finally, a small plug for our concise orthopedics notes. It's a book written by the mentors, specifically we feel best geared for the FRCS exam, but it does help with the international exam as well as the European exams. We recommend it highly as a good study guide and preparation for the exam. Proceeds from this go to helping running the mentor website and these webinar sessions. Thank you very much, everybody.
Thank you very much.
No other comments about dislocation. We'll pause here and start our Viva session. Thank you, everyone.